Yeah. So we'll move on to our second case from Medicine 4 by Dr. Vivekananthan, the bent puzzle.
Good morning, all. I'm going to discuss topic about the bent vessel. A 38-year-old lady, Mr. D, housewife from Kudiyatham, presented with the complaints of fever for past 6 days and rash over the upper limbs, involves upper limbs, face and trunk for the past 6 days. Polyarthralgia for also the past 6 days and reduced renal discomfort for the past 1 day. On history of presenting illness, she was apparently well before 6 days. Then she developed a fever, low grade, intermittent, not associated with chills and rigor, and associated with erythematous rash involving upper limbs, trunks, and face. She also had a history of polyarthralgia involving upper and lower limb joint, small and large joints, not associated with mucocutaneous lesion or alopecia or dry mouth or dry eye or Raynaud's phenomenon. She had a history of chest discomfort for the past 1 day, pain more severe when lying down, and relieved by sitting position, not hereditary in nature, no history of nausea or vomiting also. She had no history of cough with expectoration or breathlessness or sore throat. She had no history of syncope or altered sensorium. She had no history of swelling of lower limbs or reduced urine output. On past, she had no other comorbidities and she had no other addictive habits also, no significant family history. She was treated outside with the injection ceftriaxone for the above illness. On initial presentation in the ED, she was presented with a pulse rate of 40 beats per minute, which was regular. After 1 mg of atropine, heart rate was 110 beats per minute, BP was 150/90, respiratory rate was 18 cycles per minute, saturation was maintaining at room air, temperature was 98 degree, fever at the time, GRBS was 225. And vital signs in the ward, pulse rate was 58 beats per minute, BP was 120/70, and the respirator was 18 cycles per minute, saturation was 98% at room air. She was presented as a pallor, diffuse erythematous rash, maculopapular rash present over the upper limbs only at the time. No icterus, cyanosis, glubbing or pedal edema or generalized lymphadenopathy, and thyroid breast examination normal, oral cavity normal. Swelling of joint counts was 0, tender joint counts was 6 was there, and other systemic examination was nothing significant. The differential diagnosis we consider as a viral myocarditis, Coxsackie virus, or dengue fever with MARS, scrub typhus with multi-organ dysfunction, leptospirosis, Druss syndrome, rheumatic fever, or adult onset Still's disease. Sorry. She was presented with a blood profile of hemoglobin 9.1, which was microcytic hypochromic anemia. Total leukocytes counts are 5,000, and neutrophilic predominant, and with platelets are 1,74,000. When the liver function test showed there is a transaminitis, and uric creatinine was normal level. Troponin level was seen from the ED, it was initially 27, and the ward 24.2. Again, it was increased to 88.7. CKMB level was 1.6 at the time of ED presentation. It was 2.4 at the time of the ward presentation. And ECG 3 times repeated, it showed no ST dynamic changes, but the initial ECG showed there is a sinus bradycardia. Other tropical fever workup also we sent. It was scrub negative, dengue negative, and echocardiography in the bedside and the routine echo also was normal study. The echo was the ECG was at the time of presentation in the ED. It showed sinus bradycardia. I could not able to get the picture of my patient. It is the same presentation of the my one of the published paper in that. Can anyone identify that?
Chikungunya,
chick sign. Chikungunya fever, it is a crippling arthritic manifestation of disease spread by the Aedes mosquitoes. In India, most commonly the Aedes albopictus was predominant, and that in chikungunya there is a saddleback type of fever. Fever which was 4 to 8 days for fever abates and recruits after up to 2 weeks. The IgM antibody titer rise in the acute immune phase, and the IgA antibody titer will rise after that in the end of the acute phase, In the late phase, most predominantly due to the humoral response. The symptoms of the chikungunya fever patient present with the arthralgia or malaise to the frank arthritis and saddleback type of fever, polyarthralgia involving the small joints and site of previous injury sites, myalgia. This it's a fever pattern of the chikungunya fever. It was initially up to that up to 4 days it will rise about that, and 4 to 8 days it will abate, and again it will rise up. The rash initially starts from the first day of illness. Face, neck, and later involves the trunk and both upper and lower limbs. The other symptoms are involved headache, photophobia, vomiting, or retroabdominal pain, or sore throat with pharyngitis. Investigations which showed normally present with the patient with leukopenia with relative lymphopenia, thrombocytopenia, ESR and CRP will rise, and increase in ALT and decrease in prothrombin time. The other organ manifestations are which are rare, but patients which are present with the Guillain-Barré syndrome, myocarditis, or hepatitis, and encephalitis. The most common cardiac involvement in the chikungunya fever are myocardial hypertrophy, ventricular dysfunction, and pericarditis and coronary artery dilatation. And in one of our studies showed that there is a 21-year-old female also present with the same kind of presentation, but this patient present with the ECG showed ST segment elevation with rise in troponin levels, but the MRI showed the pericardial effusion and subpericardial delayed enhancement in the apical wall of left ventricle and right ventricle lateral wall. And she was treated only with a high dose of aspirin for the chest pain. For her also, ELISA showed that chikungunya IgM positive, and chick-induced myocarditis without heart failure have been misdiagnosed during the chikungunya outbreaks in the previous studies it showed. The other study also showed like there is a the arbovirus, both the chikungunya and dengue positive patients are most predominantly present with the most rarely present with the myocarditis involvement, and the heart disease associated with the arbovirus has no specific treatment, and they may self-remitted condition, they will resolve spontaneously, and supportive therapy only was needed for this kind of patients. In our patient also, the myocarditis also was suspected, and the troponin levels also which was fall down after the third or fourth day of illness, and her fevers also was settled down, and she was treated with only with adequate analgesics, and cardiology opinion also was obtained regarding that is there any further management regarding that. There is no study suggestive of that any other supportive therapy. Thank you.
So will you just go back to that picture and tell us what are we exactly looking for and how will we identify this in our patients?
This one, the patient present with the hyperpigmentation of skin over the nasal area, ma'am, most commonly predominant. Our patient also was presented with, but we could not able to take the picture. We take the picture, we missed that. Sorry.
Okay, sure. So ideally, all of your differentials, if you can go to that list, you can get fever with rash, maybe myocardial involvement. Some of what can differentiate it is the kind of rash. So, for example, I think Coxsackie rash is different. I think it's like a blister-like rash. So, so I know that we just think often rash, okay, we'll ask dermatology about it, but the different types of rash will tell you which is more likely, specifically here, the hyperpigmentation. So ideally, in your clinical description of the case, even if you don't have a photo, you'd want to say there's a maculopapular rash diffusely, but on the face there is hyperpigmentation. That is what is.
are wrong, no? It means the blood vessels are involved.
Yes.
So in myocarditis, the blood vessels involved?
No, ma'am.
Huh?
No, ma'am.
So when a muscle fails, what are the symptoms you'll get? The pump has failed.
Breathlessness, they will have.
Yeah, they'll have breathlessness and features of heart
heart failure syndrome.
Heart failure. So that is what Dr. Thomas is asking. Did your patient have any symptoms of heart failure?
No, ma'am.
What are the symptoms of heart failure? That is?
Elevated JVP.
Signs. So you're telling me signs. Elevated JVP then?
And pedal, right heart predominant, it will be pedal edema, left heart it will be
so myocarditis, there'll be biventricular failure. That is the concept. You don't have localized myocarditis. So there'll be biventricular failure. So there'll be both left and right heart failure. Yes. So elevated JVP, S3, crepitation, pedal edema, all those are the signs of myocarditis. Yes.
It sounded like your diagnosis of myocarditis came from the bradycardia, which is also not typical of myocarditis, as far as I know. Usually there's a tachycardia, which is like in response to the ventricular failure. It's like a compensatory response. So that itself is not necessarily, doesn't necessarily mean the heart is involved. I think many infections, including dengue, typhoid, can have some bradycardia, which I'm not sure about the exact mechanism, but it doesn't necessarily mean there's inflammation of the heart, the cardiac, the myocardium. So, thank you.